I would like to welcome the participants who have joined us for the Community Health Science and O'Brien Institute seminar series today on the Calgary Audit and Feedback Framework, CAFF, a homegrown evidence-informed approach to improving physician performance. I would like to take this opportunity to acknowledge the traditional territories of the Treaty 7 region in Southern Alberta, which includes the Blackfoot Confederacy comprising the Siksika, Piikani, and Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda, including the Chicoutimi, Bearspaw, and Wesley First Nations. The city of Calgary is also home to Métis Nation of Alberta, Region 3. My name is Diane Duncan, and I will be moderating the session today. I'm a project manager with the Physician Learning Program and contributed to the development of the CAFF model. I'm very pleased and honored to be introducing today's seminar presenter. Dr. Cooke is a professor of neurology and the head of the Division of Neurology in the Department of Clinical Neurosciences. She is a medical educator and the former Associate Dean of Continuing Medical Education and Professional Development, where she led the development of the CAFF model and the Physician Learning Program. I'll just let attendees know that you may ask questions using the Q&A box, which will be addressed after the speaker's presentation. The webinar will be recorded, but if attendees have follow-up questions, they may contact iph@ucalgary.ca.
Thanks, Diane. I think it's time for me to go now. I appreciate the introduction and also that you were willing to moderate this session. You got pulled in at the last second, so thanks very much. I'll just share my screen. Okay, are we looking at the right screen? I'm going to assume yes, unless someone tells me otherwise. All right, so today I'm going to present to you culmination of many years of work by many people with a focus on research around the Calgary Audit and Feedback Framework, which was developed here in Calgary and which we're very proud of. I'll start with some disclosure. Really, there isn't much to disclose, although I would like to acknowledge the Office of Health and Medical Education Scholarship, who funded the last piece of research that I'll share with you today. Most importantly, I want to acknowledge the huge number of people involved in the work that I'm going to be sharing. I put a big red star next to Drs. Lee, Lockyer, and DeGuerra because the whole concept of having a physician learning program in Alberta was actually their brainchild several years before I got involved with it in 2012. All these other wonderful people have worked or do work with the Physician Learning Program or parts of the AMA and have supported this work. The objectives for our discussion over the next short while will be as follows. We are going to cover some of the key literature on CPD, which is continuing professional development, and on audit and feedback. We'll talk a little bit about the evolution of the Physician Learning Program and the development of the Calgary Audit and Feedback Framework, and we'll describe some of the research that has come from this work over time. So we'll start with a scenario. That's how we like to teach in medicine, is always with a scenario. So I picked on my own people. A group of neurologists want to achieve their self-assessment Section 3 credits for their maintenance of competence. We have to have 25 credits per cycle. They decide to review how they're managing inpatients with a new diagnosis of epilepsy, and they've chosen 3 metrics to measure. First is that patients have outpatient follow-up organized with a neurologist. Second is that there's documentation in the charts of these inpatients about seizure safety. And third is that anti-epileptics were prescribed appropriately. So all of the physicians believe that they meet all of these 3 expectations consistently, but a data collection from chart reviews of all of the epilepsy patients they saw over the previous 6 months suggests otherwise. Data report cards are emailed to the doctors. And so questions for you to think about, and if you want to, you can say what you think, is do you think this is audit and feedback? And do you think this will lead to a practice change? And that's really the $1 million question, and we're going to talk about that over the next 45 minutes. So first, let's discuss what is audit and feedback. Audit and feedback really is where we give an individual their professional practice or performance data, which is measured or extracted from administrative health systems data. And then it's compared to either peers or a gold standard and fed back to the individual, with the ultimate goal being that if a gap is identified, that they would then change their behavior or change their practice. So that's what audit and feedback is. And so the next question is, why should we be thinking about audit and feedback in the context of physician professional development? And I'm going to talk about the why of this for a few moments. First, really, there's a pressing need for us to find ways to help physicians to improve performance, to learn and adopt new strategies for delivering care. And some of this comes from what we know about the relatively staggering levels of medical error seen in health systems. And while not all of that has to do with physician behavior, certainly some small part of it must at least. We also know from a fairly extensive literature going back to the 1980s that traditional didactic CME approaches, where we would all sit bums in seats in a room, don't reliably improve performance or patient outcomes. Sometimes they can a little bit, but it's actually not very impressive data when we look at it. And so people who've been involved in trying to improve continuing professional development have started to look towards the scientists that live in the knowledge translation realm, which I'm sure many of the people on this call do, to try and find answers for how can we help improve physician performance. So in the land of knowledge translation, which has existed in the past quite separately from medical education, we think about this as a transdisciplinary field, and it involves theories from organizational effectiveness, sort of cognitive psychology, educational psychology, learning theories, and brings those together to try and understand what type of intervention is appropriate in what type of situation. And audit and feedback is one type of knowledge translation strategy, but there are many others. And of course, audit and feedback is only appropriate some of the time, and we can't be sort of left in that situation where the only tool we have is a hammer and everything starts to look like a nail, because audit and feedback is just one tool, and there are lots of other ones, but we're going to focus on that one because there's quite a lot of interest in it in the literature and in the professional development field, especially in Canada right now. So the first question is, does it work? And this is a slide from a really lovely Cochrane review that was done in 2012, and they're actually redoing it now. They've been working on it since before the pandemic, but I think progress has been slowed because of the pandemic, because it pulled a lot of us off the work. This Cochrane review included 140 studies of audit and feedback interventions. And basically they showed that yes, they work. They can move physician behavior by a measurable amount, but it's highly variable. And it seems that there are certain factors that can influence how effective the intervention is, how the feedback's delivered, whether it's given verbally or written, if it's given more than once, if it includes specific targets and an action plan. So these are all principles that you see sort of sprinkled around in knowledge translation and implementation science work. And here it is facing us as medical educators as something we should be paying more attention to. What's important to think about, though, is this variability in the effectiveness. And if we look at this meta-analysis, really, it ranged from huge effect sizes to even having a negative effect on physician behavior. So the interquartile range was really large, and there's not a reliable response to audit and feedback. And so we were kind of interested to know why that was when we were building the physician learning program, which I'm going to talk about more in a moment. So what we do know is that it's probably more effective than traditional models of continuing medical education or professional development. Although to be fair to myself and everyone else who works in the professional development field, there is still some benefit to traditional models of CME where we sit in a room and we learn a thing. It's certainly better than nothing, but it seems that audit and feedback, when carefully applied, might be more effective than that. So I'll tell you now about the intervention that we're going to be talking about when we cover some of this research over the next short while, and that is the Physician Learning Program. And this is a program that was established in 2009, and it was really the brainchild of Drs. Chris DeGuerra, Jocelyn Lockyer, and TK Lee. Chris and TK were at the U of A, and at that time, Jocelyn and Chris were counterparts as Associate Deans of Professional Development at the two universities. And they went to the Alberta Medical Association and said, listen, we give doctors a lot of money every year to reimburse them for CME activities where they go and sit in a conference room. How about if we invest in some potentially more effective means of changing performance for physicians. And so that's how this program was born. The AMA got a grant from government, and it was billed as a physician benefit program. And the idea was that it would be a physician-driven program, driven by physicians for physicians, to support physician learning by giving doctors access to their own practice data and ostensibly hoping that they would improve their practice once they received this feedback. The idea of having it live within the AMA was to keep it at arm's length from the funder, which was government, and from regulators like the college, so that it would really be seen as an educational intervention rather than as a summative or assessment type of intervention. So really a big mandate, and if any of you have worked with administrative data, you know that it might have seemed like an impossible thing that we were going to somehow provide feedback on individual practice data to somewhere between 9,000 and 11,000 doctors because someone gave us money to do so. And that's what we learned over the next several years. When it started, our funding was unstable due to government negotiations. Doctors were quite terrified of the idea that a group might come and look at their practice data. A lot of questions doctors had that they were interested in weren't answerable using administrative data. It takes a very long time to get data, clean it, match it. Some of the questions we chose to try and show people what we could do turned out to be not very interesting to the doctors we presented them to. Our reports were probably too long. A lot of the data graphics were impossible to interpret. We tended to measure what was easy to get access to and easy to measure. And of course, that's not always what's important or interesting. And then we would do these didactic sessions where we would present these huge long data reports, and the responses would sometimes be crickets and sometimes kind of a, so what? And this is an example of one of our early data reports where we basically gave a bunch of urologists data on what kind of antibiotics they used post-operatively from a TERP. And as you can see, there was not really a comparator to peer group. There wasn't a gold standard. And so they had this information and they said, yeah, well, we kind of do things differently across the board here, but so what? So over time, we learned, and through a lot of trial and error and really through making a lot of mistakes, we found out all the things that can go wrong when you do audit and feedback. It takes too long to get the data's dirty, the data can't answer all the questions. We don't really always think we understand what doctors want to know about, but we're often wrong. Docs are skeptical about the data. We spend too much time trying to help people understand what the data means. And sometimes the groups just weren't interested. So these were the things we were learning through the school of hard knocks. But each time we learned something, we changed our approach a little bit. And ultimately, we had a more smooth and slick process. And so how it evolved is that physician groups, as opposed to individual physicians, would identify an important clinical question and bring it to the PLP. If it seemed likely that we'd be able to get an answer for them, that the answer would be actionable by physicians, because this is a physician service, and it was actually clinically important, then it would become a project. The PLP would then collaborate with data custodians to extract, clean, and match the data. Then we would create confidential individual data reports that contained comparators to either their peer group or gold standard. And then this is the really important piece of what we were doing that I think was quite unique. We would then facilitate or co-facilitate with a member of that group a feedback session, and everybody would be there. They would have received their reports in advance, and they would be encouraged to walk through a process of reflecting on their data and enacting change from there. We got a graphic designer involved, and that helped us have better visualization of our data so that it was easy to pick up on what it meant and was more compelling for the people on the receiving end of the reports. And we also started to see some results. We were starting to see changes in outcomes or practices and behaviors on the physician side after giving a repeated series of reports with facilitated feedback. Now, at the same time, there's a very prolific and important group working on the same thing in Ontario, and they put this great paper out in 2014 that pointed out that publishing paper after paper saying we did audit and feedback and it worked, and this is what happened, is not actually really contributing anything much to the literature. We really needed to understand what worked and why. And here in the PLP, in the meantime, we were starting to think we did have a feel for what worked and why. The next thing that happened was this wonderful paper came out. And at this point, we had already started to have some ideas about what was important to doing a good job of audit and feedback. And when we read this paper, I think Diane and I in particular were really excited because we thought, we're doing most of this. So let's look at what the suggestions were for optimizing audit and feedback that came out of this very prolific and leading group in Ontario. This isn't everything that was in that paper, but the high points. And what you'll see here is, although I mentioned earlier that the education folks started to look to KT, what I saw as someone who's really a medical educator when I looked at this paper was the KT folks started to look towards education literature. So when you look at this graphic, you can see there's some elements here that are very clearly out of the implementation science world. So you know what, the action you identify that you want to work on is actually actionable. Say that 5 times fast. There's comparators or a gold standard to measure by. The data visualization is solid. You're going to address barriers to making the change. These are all principles of knowledge translation. But these 2 items really had not garnered a lot of attention in the audit and feedback realm in the past. And that's looking at the nature of the feedback itself. So remember, most of the data that was in that Cochrane review was about projects where people got a report card on their performance. So it comes into the inbox, they look at it, and then they decide if they're going to do something about it. Or maybe it might be a one-on-one discussion with a boss or a QI lead, but that's it. So suddenly the recommendation is the feedback credible? Because that probably influences how well it's taken up. And they talk about constructing feedback through social interaction. And that had really been a missing piece through a lot of the literature that was reviewed in that big Cochrane review in 2012, because most of the time there's no social interaction. It's just a report card that shows up in your inbox. And we were all over that because of the way that we kind of had to do business in order to reach as many doctors as we could through our program. So we had a series of research questions that had sort of arisen in tandem with when these papers started to come out of Ontario. And I'll share those questions with you. Because of what we were seeing in our work, we started to wonder about how is it that physicians behave when they're in a group setting doing audit and feedback work with their peers. And then what mediates the success or failure of a given audit and feedback group, because we had definitely seen lots of both. We were interested to know if we had a solid model, which we were starting to evolve, whether that would impact how subsequent audit and feedback sessions went. And of course, we're always, as educators, thinking about how do we evaluate the program that we've been building. And so those are the 4 research questions I'm going to try and run us through in the next 30 minutes. So the first question is around physician behaviors in these groups. And this came from an early morning session that we did at the Children's Hospital. Diane, I can't remember if you were there or not, but it was the first one that I had watched where we did an audit and feedback session with the group. They had their reports. We had a facilitator from our team and then this room full of pediatric anesthesiologists. And I was watching the discussion and I thought, I wonder if this happens in all of our groups. And I talked to our project managers and they said, yeah, you know what, it kind of does. So we started to notice some patterns in physician behavior when you had these small groups. And if you think about what you know of human nature, it's a bit intuitive, but I wondered whether or not we could use this pattern to influence how productive these group meetings were. And so from that came our first paper about the PLP, which was about how physicians behave when they participate in facilitated group audit and feedback sessions with their peers. And I'll describe to you what we did. After that first morning session at the Children's Hospital, we decided to start recording all of our audit and feedback sessions because we thought we could probably analyze the patterns of behavior from transcripts. And so that's what we did. So we ended up with 6 audit and group feedback sessions at 4 hospitals across 3 disciplines, including 50 doctors. And we had transcripts from all of these. And so we essentially did a qualitative analysis, a fairly simple one, a thematic analysis, to try and see whether these behaviors actually happened in a patterned kind of way. And of course, they did. And so this was the conceptual model that came out of that work. And so almost 100% of the time, what we would see is time would be spent reacting to the data. So physicians would sometimes express defensiveness, skepticism. Some physicians would be excited. Some physicians would start saying, wait a minute, is this for real? As they were a little uncomfortable with what they were seeing in their data report. Then there would be a process of sort of toying with the data. People needed to understand what administrative data can and can't do, what are the limitations of the data, and they needed to understand the graphics that we presented them in their reports. And so if we did a crummy job of visualizing the data for them and it was difficult to understand, a lot of time got wasted just trying to understand their data reports. Once they understood the data in front of them, there would be this process of trying to justify and contextualize And this would be sort of discussion that would be along the lines of, oh, you know why it looks this way? Because of this, or our center or our site looks different because we handle this population and not that population, or my data looks differently because I do the following. And so some of this could have been born of discomfort from what they were seeing, or simply just trying to understand the broader context of their data report. From this piece of conversation, inevitably, the docs would start to share their practices with one another. And they would compare notes, and you would see people looking over their shoulder at the doc next to them and saying, what did you get for this? I do it this way. What do you do? And then someone would say, well, did you see this recent guideline or this recent publication? And then if it was a good session, the next thing that would happen was change cues. And these are probably the most important part of the audit and feedback session. And I'm going to talk to you a little bit more about what these are. So change cue was something that we witnessed again and again, at least in our sessions that we felt were more successful. And this is a turning point in the group discussion where there's basically some person in the group, in the audience, makes a brief comment which highlights how important a particular performance gap is that was revealed by their data report. It's raised spontaneously, and it's usually a member rather than the facilitator of the group. And when a change cue would happen, one of two things could happen. Either nothing, because the facilitator would say, and just carry on to the next data point in the data report. Or if the facilitator was attuned to it, they would respond and there would be an ensuing discussion around making change in response to the identified gap. So in our model, we presented change cues and change talk together as one important element of it, because what would happen is whenever there was talk of change, it always came from a change cue, which just floated like a little balloon out of the discussion from a member of the group. But not all change cues were followed by change talk, and that really seemed to depend heavily on how effective the facilitator was in recognizing it and then addressing it with the group. And so why do we care about these? Well, we think of change cues in this context as very much an element that leads to commitment to change. And if you look at the professional development literature, there's quite a bit of evidence to support the idea that commitment to change ultimately increases the likelihood of making change. So you could almost think of it as a loose proxy to ensuing change coming out of a discussion that happens. And some interesting work that came from Dr. Heather Armstrong, who is also here in Calgary, and her colleagues, was that the more cognitively complex the commitment to change, the stronger the correlation with the behavior change. And there's actually quite a bit of literature if we look into cognitive psychology and early learning theories that supports what we were seeing and explains what we were seeing in this cycle of behaviors that was repeated again and again and again across these groups. So Bandura talks about social learning theory, where we observe the people around us when they're doing things and we learn from what they're saying or doing. And of course, this comes from early childhood education. There's Vygotsky, who talks about the zone of proximal development, which sort of refers to the influence of the more knowledgeable other. So if there's someone in your group that you think might be smarter about something than you, or that you respect, and they say, hey, this is important, it's more likely to become important to you. And if they endorse a change, you're more likely to endorse it also, by virtue of their presence and the perception that they're more knowledgeable. Adson is the creator of the theory of planned behavior and talks about subjective norms. And that's where in a group setting, there becomes a sort of perceived social pressure to change. So if a bunch of people in a room start nodding their heads and saying, yeah, this is important, hey, we should do something about that, the one person who might have felt otherwise is actually more likely to change their mind and engage because of the social norms. And finally, some more recent literature talks about achievement goal theory, which talks about what motivates people to undertake learning intervention or change. And they talk about avoidance, so not wanting to appear incompetent, but they also talk about mastery goals, which is where people want to be perceived as competent. So people want to perform similarly or better than their peers. They also, in some of the more recent feedback literature in medical education, talk a lot around the relational aspects of feedback and what may lead to feedback uptake. And this has to do with the relationship between the person providing the feedback and the person receiving the feedback. There's a concept of the educational alliance, which is sort of like a therapeutic alliance for those that are familiar with psychology. There's the trust in the provider. There's also the nature of the facilitation, and the R2C2 model, which was developed by Joan Sargent and Heather Armson and Jocelyn Lockyer, and has a fairly sizable body of literature now, really focuses on the nature of the facilitation and the process of facilitation and how that influences feedback uptake. So we think that the combination of all of these theories is probably influencing what we were seeing as how physicians behave in these group settings. And we think is pretty important because it seemed like these interactions within the group, as opposed to the interaction just of us telling them things, actually led to the change cues and change talk. So the next big research question for us was, why is it that some of these groups seem to work better than others? And it was very clear in looking at the transcripts and also living through these sessions with our project managers and team leads, that some of them went really well and led to cool things and interesting innovations. And others were sort of, those sessions where the crickets came out and no one really said anything and they all took their reports and walked away. And we wanted to understand why. And so how do we define success? Well, not all of our projects led to changes in patient outcomes because we weren't measuring patient outcomes in many of our early projects. So we looked at success in these sessions as how much time was spent on change planning as opposed to getting buried in the weeds of understanding the data or justifying the data. We looked at how engaged the physicians were because it seemed that crosstalk across the groups led to discussion around change. We looked at the extent to which these groups then requested further data pulls and further projects. For example, they might see their data and say, you know what we need to really know? We need to understand this other problem because then we can fix this first problem. And so there were often requests for subsequent data draws and subsequent projects. And of course, for some of our projects, we could see that change had occurred. And so those are sort of our metrics to decide whether or not a project was a successful one or not. So in terms of what was mediating success or not, we were very interested in this question. And so we elected to do a comparative case analysis. Many of you will be familiar with this methodology, so I'll just kind of whiz through it. It's a methodology borrowed from the social sciences, certainly taking up a lot more of the literature in medical education and KT nowadays. Basically, the idea is that you build a program model, so what we think is happening based on what you've observed and published theories, evidence, consensus. And then you find data sources. That could be any number of things like interviewing staff or participants in the intervention, looking at documents like data reports, process evaluations, transcripts, field notes from interviews. And you extract the information from the data sources and try and fit it into your model. And if there's bits and pieces of it that don't fit, then you adjust your model until you've kind of got a home for all of the findings. And then you compare, looking at what are the factors that distinguish between the different types of cases. So the rough kind of overview of our program model looked like this, and we thought that these elements probably all influenced success in various projects. And these elements were drawn from our own observations in our first paper, but also from the literature in both medical education and feedback, so looking at things like the R2C2 model, but also looking at knowledge translation frameworks like IPARIS and the theoretical domains framework as examples. All of these things sort of were coming together in a way that suggested what might work and what might not work in audit and feedback. So that's how we built our program model. We found a number of kind of key mediating factors that seemed to map onto what we had observed with our different projects. And these had to do with the things I've alluded to already, the relationship with the group, how we picked our questions, the context and culture of the group seemed to play a huge role, the nature of the question, the report itself, and then very much how we facilitated the groups. Because if we missed those change cues, we missed opportunities to plan for change. And so this is where the Calgary Audit and Feedback framework was born from. And we published that one later in 2018 as well. And I'll show you what it looks like. Basically, it boils down to two core components. There's the design piece where we're going to undertake an audit and feedback project with a group of doctors. There's a whole bunch of things that need to happen before we actually do the feedback session. And then there's the feedback session itself. And at the bottom of the model here, what you're seeing is that same cycle of physician behaviors, but it's stretched out this way, kind of to show how the elements of the actual implementation framework might drive the behaviors through that cycle towards the goal of planning for change. So the pre-work that needs to happen when we're doing an audit and feedback implementation, first and foremost is relationship building. A huge barrier for us early on was actually around trust. Physicians are really afraid to let us look in the underwear drawer. They don't like to let us look at their data. They're worried about being found to be imperfect, which of course is a fallacy, because none of us is perfect. They're worried about being seen to be less competent. They're worried about assessment, getting in trouble, all these different things. And so they're very uncomfortable at first blush with the notion of people looking at their data. We needed to show them that the intent of the program was for learning, that it was for feedback, that it was for making us better at doing our jobs and taking better care of our patients. We needed to show trust in the data as well. So a lot of groundwork had to be done working with the groups and an engaged physician lead to make sure that that relationship and trust was there. And part of that was also making sure we got it right. And so that meant once the trust was in place, working with them to identify what was the right question. So question choice, there's so many elements to this, but obviously not all questions have, their answer available in administrative data, and also audit and feedback is not the right way to address all concerns and questions. The really critical factors are, is the question actually important to the physicians? We certainly found out what happens when you ask unimportant questions. The physicians kind of say, okay, so what? Is it actionable? Because if we give physicians a bunch of data on something that needs to be improved, but over which they have no control, it will fall flat. And then it's also really important that the people leading the project on the physician side and on the PLP side understand what the data limitations are. Sometimes the best we will have is a proxy measure, and everyone needs to understand that. Everyone needs to understand that there's always lots of confounding factors when we use administrative data. And so a very important piece of all this is preparing the group to understand the limitations of using this kind of data. And finally is the data representation. The data representation is so critical. If it isn't interesting and immediately compelling and easily understood, you quickly lose people's attention. Physicians are busy people. And if you have a group of them in a room and it's lunchtime and the food is good and they have an iPhone in their hand, if they can't immediately understand what you're presenting, they're going to eat their snack and check their email and not learn anything from the session. So visualization was actually critically important. In the sessions themselves, facilitation wound up being one of the more important elements. What we learned over time is that things worked better when we co-facilitated with a member in the group. And that logic actually drives out of the IPARIS framework, where they talk a lot about facilitation in order to make an intervention successful. The facilitator really needs to have a handle on the local context. So even though the speaker at the feedback session might have been a member of the PLP team, if the recipients were orthopedic surgeons and the facilitator wasn't an orthopedic surgeon, it didn't matter. You really needed an orthopedic surgeon from that peer group to be a part of the facilitation process, because they would understand the local culture, all the different factors that influence behavior, and so on. And then there were the sort of the nature of the facilitation. And that really speaks to those relational issues that I mentioned a few slides back, and really trying to take that sort of mentoring, coaching, understanding and fairly nurturing approach, which is really emphasized in the R2C2 model of feedback. So when those elements were in place, what we saw is that there was less skepticism, and that people were able to sort of work their way through this cycle out towards change cues, change talk and planning, and then from there to build an implementation plan that hopefully would lead to change. So that's the Calgary Audit and Feedback framework. So this next piece is not yet published. Diane and I did the work and I think got distracted by other jobs after that. But we did look at 5 more audit and feedback groups after we had published the model. And these groups had much better fidelity in terms of how the model was implemented. And we did a framework analysis, which is a method of qualitative analysis where you basically go in with some very clearly preconceived ideas of what might be present in your data. And that's sort of what you do a priori, and so you have a set framework. So in this case, the framework was the CAFF model. And so we looked at these transcripts to see whether we could appreciate any benefits to having this fidelity to the model as we designed it. We had some just fairly high level observations out of that. The one observation was just proportionately a lot more of those focus groups was spent on on the good parts, talking about reflection and sharing practices, change cues and change planning, and less of it was spent on skepticism and questioning and saying, yeah, but we're different because, and so on. And some of that had to do with having done adequate preparation with the group, we think. And some of that was to do with the coach or the facilitator, because we ended up co-facilitating these sessions, and we would do an actual training session with the R2C2 model with the co-facilitator. So they really knew what to watch for and how to keep people moving along that cycle. The other observation that we made is many of these groups were people who had been involved with previous successful projects. And something that we could see was that there was an evolving level of sophistication in terms of interacting with administrative data, understanding what it can and can't do, and also understanding what as physicians we can and cannot do by ourselves to make change, and who else might need to be pulled into the discussion to make change. Since then, I'll just say sort of at a high level, we've had innumerable individual projects that have shown that the model works. There are lots of abstracts and publications of individual projects that have gone out there into the world where we've used the CAFF model and shown changes in physician behavior. Examples looking at the use of a certain drug in the operating room that reduces the need for blood transfusions and joint replacement surgeries. Another looking in the PEDS emerge department at bronchiolitis, which is a common presentation to the emergency room with respiratory infections, and trying to reduce unnecessary care in the care of those young patients. Those are two, I think, of our projects that we're especially proud of, because the outcomes from that led to changes in patient care in a very meaningful way. And the fidelity of those projects was really good in terms of lining up with what we had intended to do with the CAFF model. So the next question that we always think about, and again, my background is in medical education, I'm always interested to know, how do we evaluate our interventions? This was a really complicated intervention. And evaluating complex interventions is complex because there's a billion confounding factors. There's the program itself that needs evaluating, but then there's all the individual projects, the impacts on the physicians, the physician groups, impacts on the system. We wondered if we were impacting things at a higher level in the healthcare system. And so how are we going to untangle all of this? And just coincidentally, I came across an evaluation method that I hadn't seen before, because I was doing some work with the Royal College looking at the competence by design model of residency education that we've evolved to over the last few years across Canada for specialty training and in family medicine. Again, a really big, multifaceted, complicated intervention. And we had an evaluations expert on that team who knew all about all forms of program evaluation. And she floated the idea of doing outcome harvesting for competence by design. And ultimately they decided not to use that, and for good reason. But we decided we would give it a try as a means to looking at what are the outcomes of the PLP and the projects that we've been doing. And so really, what is outcomes harvesting? It's a method that is not used a whole lot in the evaluation of medical education interventions. It is used somewhat in public sector interventions. So you'll have an NGO that might go into a country and implement a program, and this might be a means of looking at what outcomes the program achieved. The idea is that in a complex environment, you want to try and find all the things that might be an outcome of your intervention, and then describe them and work backwards from the outcome to try and determine if and how much the outcome could be attributed to your intervention. And the neat thing about the outcomes harvesting, and I think why this caught my attention, is because the ideal situation is that it actually captures both intended and unintended outcomes of whatever the intervention is. So I'll share the methodology with you. And basically your first step is to design the harvest, which is basically deciding what questions am I going to ask. Then you gather the outcomes, you verify them with people who worked on the project, and then you substantiate them with people who may have been end users or stakeholders. And then you basically have this huge database of outcomes, and you kind of try and organize it in a meaningful framework that says, when you do this type of an intervention, these are the things you might see happen. And ideally, you disseminate that, as we're doing right now, so that other people can use that information in their work. So our questions were really about what was the effect of audit and group feedback? What has been the overall effect of the PLP? We started out with a huge document review. We basically took everything that we had access to from the program. So these are just simple things like minutes, business plans, strategic plans, retreat documents, presentations, meeting minutes. We had, aggregate anonymized data reports. We had field notes, we had transcripts, we had previous publications, abstracts. We went through them and grabbed anything that looked like it could be an outcome and put it into a big database. Then we worked with our team and our change agents or team members who were very involved with the projects to try and make sure these were appropriately written so they were correct and made sense, and also to verify that they seemed like legitimate outcomes from the projects. And these were people who knew the projects well. And then we interviewed external substantiators. So these were health system leaders or people who were external stakeholders in the projects we did or the program itself. And we asked them to substantiate the outcome or not, if they felt it wasn't an outcome. Let us know if we missed any, and then to describe to us the extent to which they think PLP contributed to this, whether it was a direct impact, couldn't have happened without the program, whether it helped a process that may have already been ongoing, or this was going to happen anyways, and turns out we didn't need your help. And then was the outcome important? That was the other important thing for us to find out. So I'll give you an example from the bronchiolitis project that I mentioned. So this is a project that's been published. This was trying to reduce unnecessary testing and treatments in the emergency department at the Children's Hospital. The outcome extracted from one of the documents we reviewed was that in the time between feedback sessions, all of these different things were used less by the doctors in the emergency department. So the outcome description that we crafted with our internal substantiators is that we reduce the use of low value interventions. And then we worked with the project leads to find out whether or not this could be substantiated. So our project manager felt, yes, this was probably an accurate description of the outcome. And then the medical lead for the project also felt that it was, and was able to go further to say, in fact, there's no chance this would have happened without this project having been done. So it wasn't something that was already in play. And that was actually very important because it meant that there was a measurable difference in people adhering to recommended guidelines and using best practices in the care of these children with these nasty coughs who come into the emergency room. So the overall results from the outcomes harvest, we reviewed 62 program documents and over 150 abstracts and manuscripts. I think it was 116, but forgive me, I don't remember. We spoke with 10 internal stakeholders to validate them. And then we have external stakeholders. I think we have 11 earmarked for interviews, but all of this has been done in the context of the pandemic, and many of these people are health systems leaders, including myself, so we've been busy. So we still have 4 more interviews pending. Our initial outcomes database contained 150 tentative outcomes, but when we looked critically at these, a lot of them weren't really outcomes, they were outputs. So an outcome is we reduce low value care, and output would be like we delivered 150 audit and feedback reports to this group of physicians and they liked it. So we looked really carefully for things that were more truly outcomes, not outputs. And that boiled down to 22 once we removed duplicates, because we saw the same outcomes over and over again across a lot of projects and a lot of different documents. So in the end, we found 22. And then when we spoke with our internal substantiators or stakeholders, we had a couple of additional ones added. And then we've had almost all of these externally substantiated. I'll share in a minute some of the ones that we're still working on. But our preliminary framework, we categorized things into outcome categories because there were a lot of things that sort of overlapped. We have about 12 outcome categories, and some outcome descriptors fit into multiple categories. So this is a rough look at our sort of early framework, and this may change in the next couple of weeks because we're actually still finishing this part of the work. So the first is there were innovations. We had a new model for delivering audit and feedback, made a contribution to the science of audit and feedback. We found new data resources and new mechanisms for data reporting. There was engagement. One of the things that was surprising was we found interdisciplinary engagement. So people were engaging their quality leads, other departments, nurses, allied health, and so on. We engaged physician groups more and more over time to the point where we didn't need to advertise anymore. People kept asking for more projects and different projects. We also started to see engagement across health system levels. So we had engagement from the CPSA, our regulatory college, engagement from the Health Quality Council, the strategic clinical networks. And then most importantly, we saw change. We saw changes in patient outcomes, changes in physician behaviors, changes in the behaviors of teams. We saw changes in health system processes like order entry sets in the hospital, for example. The other thing we saw that we really liked was capacity building. We saw groups of physicians become able to ask good questions, figure out how to use administrative data, and figure out how to make action plans and enact them and know who to bring into the question to help them solve it. So we saw a lot of neat changes. Now, what I mentioned earlier is that we had the idea that maybe we would find unanticipated outcomes. And so if you look in this box here, if you can read it, it may be too small. These were what we predicted from our original program model. So we expected that there would be changes in people's behavior, we hoped anyways, and we knew that there might be some novel means of reporting data. But we also did find through the outcomes harvest some unanticipated outcomes, and these are enumerated here. So we were not anticipating when we started out to see this level of interdisciplinary engagement across physician specialties, but also across health professions. We weren't expecting to impact team behaviors or nursing behaviors. There's a question mark next to this next one because it hasn't been substantiated yet, but one individual mentioned in one of our interactions with the program concerns about the risk of maybe under-prescribing because a lot of the focus around some of these projects was de-prescribing and decreasing utilization of low-value interventions. So we don't know if that's an outcome or not, but it was an important concern and we're paying attention to it. We didn't expect capacity building in the system to be an outcome of our work, although it was a nice thing to find. And then one of the things, again, that still needs a little bit more substantiating is the question of uptake of the CAFF and the projects at the level of some of our system stakeholders, like the strategic clinical networks. And so what we wonder about, and this is, TBD, is whether or not uptake at the system level may not be the same because at a whole system level, it's really difficult to maintain the fidelity to the model that we've proposed. To facilitate feedback at a province level in a way that physicians can talk to one another about their results is really challenging. And so at a system level or a province level, when we try and do audit and feedback, it often seems to revert back to report cards. And so many of you probably get report cards from the college looking at your benzo prescribing or opioid prescribing. That's an example of that. So we're not sure whether or not the CAFF can be used in the same way at a system level, and that's something we're still looking at. So in terms of lessons learned about outcome harvesting, it seems it's an effective way to identify a really comprehensive set of outcomes from a complex intervention. It is really hard work, which is why you have to undertake it carefully because it's a big undertaking to do this. But it does seem like a very systematic way of capturing outcomes, and it's not as attached to a preconceived model as something, say, like realist evaluation, where you start with a model and then you build backwards from the model. Here, you're sort of just going through everything you've got, looking for outcomes and then validating them. So it's almost like a realist evaluation in reverse. So I think it is a useful tool. In terms of take-home points from everything we've learned from our work with the physician learning program and the audit and feedback model we've developed, first, it seems very likely audit and feedback is going to be a key part of continuing professional development going forward. It's been adopted in principle at the level of our federal medical regulatory authorities, FEMRAC, because the physician improvement program that they've developed is basically audit and feedback writ large for individual physicians to ensure that they're doing what they need to be doing. And that's been implemented and is now started to roll out across the country. A reminder to all of us that providing data isn't the goal because data alone will fall flat. What we need are important questions and actionable, important information that's given in a way that people can interact with it and with their peers. How we develop and deliver and support the audit and feedback absolutely impacts the effectiveness of it. And when we're looking at evaluating these types of projects, certainly it seems that outcome harvesting may be an effective and probably underused methodology, but it does require a certain amount of energy and resources to do. And the last thing I'll share is just this cool news that we got sometime in the last 6 months, the Medical Council of Canada has awarded the Physician Learning Program team an award for their evaluation of clinical competence using the CAFF. So we feel like in terms of validating outcomes, that was a pretty nice validation for all of us that worked on this. And we're really proud of the model and hope that it will continue to get good traction with people who are working in this discipline. And I would like to thank you for your attention. Really do want to acknowledge the team of amazing thinkers who helped us with all of this work. And actually a special shout out to Diane Duncan, who's moderating, because she's always asking good questions, and her brains were behind a lot of the work that went into this model. Thanks so much for your time.
Thanks so much. That was brilliant. It was just wonderful to see the history of CAFF, because it was a long history with a lot of work. It was like birthing a baby, as you said numerous times. So we do have a couple questions, so hopefully we can fit a few questions in before the end of the session. So in terms of, what is it identifying, securing that local respected topic expert as a co-presenter? Is that challenging? Is that a hard part of the process? Is that difficult to do?
It was in the beginning because, I was actually sitting at a departmental meeting in my department in neurology, and our CME rep, this is before I was involved in CME, came along and said, hey, there's this new thing called the PLP, and these people are going to come and they're going to look at your performance data and give you a report on how you're doing. And I myself sat there and said, no, they're not. Like, heck, there's no way. So in the beginning, it was really hard to get anyone to come anywhere near this. So all that relationship building needs to happen first. But at this point, the experience has been that a lot of people are quite interested in finding ways to engage with this type of work. And so typically it'll be the person who brought the question to the program in the first place. So somebody from surgery comes and says, we're really wondering about this. Can you guys help us? And it's usually that person that ends up being the topic expert, because quite often it's someone who's a leader in some form in that group. Either someone's got a research interest in that area, or they're the QI lead, or they've got some respected role that sort of made them feel like they could bring this forward as a question. But we would do quite a lot of work to train them. And so we had sort of little train the trainer sessions with them before we would ever go to do an audit and group feedback presentation.
Yeah, and I do think that those training sessions with the co-presenters were critical, just so they had the confidence going into those sessions, and also having the physician learning, medical director there to support them. And another question, are there any differences, or do you think there's any differences on the effects or impact of audit and feedback based on the differences in physician payment models? So for fee-for-service groups versus alternate payment models?
Yeah, that's a really great question. There's so many answers to this. So it's not even just the payment model. So yes, I do think there's a difference, just anecdotally based on all the ones we've seen. Part of it is that there are groups of people who work in our healthcare system who get paid to do this kind of work. If you're on a salary and you sit for an hour during your day and review a report, or you go to a feedback session, then it costs you nothing other than an hour of your time. If it means you have to take time off your clinic to engage in the process, obviously it becomes a little bit more challenging. So it's really important to find ways to incentivize it. The colleges have done a bit of that for us, because they have made it an expectation that every physician is going to engage in reflection on their own practice data through this initiative through FEMRAC. So all of us are going to be having to do some form of this going forward. It doesn't necessarily have to be as involved as what we've presented. But the other thing we found is groups that are really tight-knit tend to engage in this really well. So if you work in a really close sort of near peer group in one clinic or one subspecialty, and you all do kind of the same thing, this works really well. Whereas, a comparison group would be some of the work we tried to do to help physicians working in long-term care looking at prescribing of sedating medications. These weren't physicians who all necessarily worked together, but they would have all received the audit and feedback, but they didn't have a cohesive group or practice group. And so doing audit and feedback in that setting is a little bit harder, because you don't have that trust and relationship piece built in yet. So I think yes is the short answer, but it's nuanced.
Yeah, and we really saw that with these tight groups, the difference versus these, less organized groups that didn't have those connections. And one more question, I think, before we have to leave for the day. Can you define a cricket? And did you observe disruptive influencers in the groups? And if so, what can be done about that? Like perhaps exclude them ahead of time if we know who they are? So how do you deal? So what are crickets and how do you deal with those disruptive influencers?
Crickets are there when there's no one speaking and the only sound you hear is the crickets. We don't like that when there's crickets in the room when we're doing an audit and feedback session. So yeah, we did observe the disruptive influencers for sure, especially in those early sessions. And I think it was probably a disruptive influencer that actually made me ask that question that early morning, that first time when we started talking about recording sessions, because I remember there was one guy in the group who kept saying, yeah, but, and it was like very clearly a discomfort with their data. And they just weren't convinced that them being different from what else was in the report meant that they needed to change anything. And I thought, gosh, we need to figure out what to do about this. And so some of the pieces that are built into the CAFF model really speak to that. And it's around building that trust, showing that the data is what it is. So we would often preempt a lot of that skepticism by saying, you know, this is not perfect data and it's dirty. Like administrative data is dirty, and anyone who's worked with it knows that. It's only so useful. And so we're looking for big picture things and trying to figure out what's important, and you're going to help us do that. So that facilitation piece becomes really, really important, and the building of trust. And so part of that is making sure that people who are co-facilitating are respected others, knowledgeable others in the group, because if they're not, that, you know, naysayer in the group becomes more powerful. But that same naysayer might also be the person in the group who floats a change queue and says, whoa, I didn't realize we were doing such a terrible job of this, let's go. And that can drive a lot of change. So really making sure to mitigate skepticism and mistrust early on, and laying out ground rules early on too, like, you know, we are not using this data for anything other than to help you learn about yourself, making clear that it's for education and improvement and not for anything more critical.
Yeah, that's brilliant. And I think we got to the point where we're saying we just want to like normalize these reactions. It's okay to react and to welcome those influencers and the disruptors. Thank you so much, Dr. Cooke. That was an amazing presentation. It was just brilliant to see the whole project from beginning to end and all the work that you've done, and looking forward to the outcomes harvesting and the real estate evaluation. So thank you so much.
Thanks everyone for your attention and for coming.
Thank you.
And thanks for helping.
Okay, bye-bye everyone. Have a good afternoon.
Bye-bye.